Hello, good morning to some and good afternoon to others. Welcome to our California Sickle Cell Data Collection Programs webinar series. I'm Yanni Coker from Tracking California's SCDC program, and I will be today's moderator. We have a great webinar planned for you today, focused on sleep disturbances in sickle cell disease. So without further ado, I'd love to introduce today's speaker, Cecelia Valrie, PhD. Dr. Cecelia Valrie is an associate professor in the Department of Psychology at Virginia Commonwealth University in the Health Psychology PhD program. She is also director of the Culture, Race, and Health Transdisciplinary Core of the VCU Institute for Inclusion, Inquiry, and Innovation, and holds affiliate appointments at the VCU Departments of Internal Medicine and Pediatrics. Cecelia uses health and developmental psychology techniques and theories to study persistent pain, sleep, and health inequities in people living with sickle cell disease and Black youth. She is also focused on testing and improving the implementation and dissemination of effective interventions to improve health outcomes and promote health equity in these populations. And so with that, I will turn it over to you, Dr. Cecelia.
Well, thank you for inviting me. I'm always excited to be able to talk about sleep in people living with sickle cell disease. Next slide. So today I'm going to provide a bit of an overview of sleep disturbances in people with sickle cell disease. So I'll start by talking about the prevalence and consequences of sleep disturbances experienced by people with sickle cell disease. I'll then go into one of my specialty areas, a little bit about kind of thinking about the sleep and sickle cell disease pain relationship, and then some discussion of clinical implications and a little bit of information about what I think are important future directions for us to keep in mind in this area. Next slide. Now, oftentimes when we're thinking about sleep, most of the time we're thinking about, am I getting enough sleep? And I think that is an important piece of sleep, but it's not the full picture of thinking about sleep. Next slide. So I want to start off by saying sleep is a multidimensional construct. It is not just, did I get enough sleep? It's also, did I get what I need from sleep? Was it good quality sleep? Did I feel refreshed? Was it efficient? So am I spending 10 hours in bed just to get 3 hours of actual sleep? That is highly inefficient. And then is it taking me a very long time, hours and hours, just to be able to initiate sleep when it should take me usually less than 30 minutes? Now, oftentimes when we think about, and truthfully, as we've been researching primarily around sleep, we focused on these like daily sleep variation pieces. But I think an important thing for us to think about is how all of these pieces come together to tell us that we might have some underlying clinical sleep disorders. And that's where I'm going to be spending a lot of my time for this particular presentation. Two of the most common sleep disorders experienced by people around the world are insomnia. So those are going to be one of our behavioral sleep problems. It's characterized by trouble falling asleep, staying asleep, not feeling refreshed upon wakening, as well as the spectrum of sleep disordered breathing disorders. So these are the group of disorders characterized by problems with ventilation and respiration during sleep, the most common of which is obstructive sleep apnea, which I'll spend a little time on a little bit later. Next slide. Now, when we're thinking about patients with sickle cell disease and what are the most prevalent sleep complications we see, they are what we'd expect: obstructive sleep apnea, behavioral sleep problems, which include insomnia, and also one that I hadn't mentioned before, which is periodic limb movement. And one thing I want to go ahead and emphasize is that sleep is interconnected with all the other symptoms and things that we think about when it comes to sickle cell disease pain and management, including sleep being linked to pain, mood disorders, fatigue, cognitive issues, and just a host of other issues. But I also want to say at this point that yes, patients with sickle cell disease are experiencing some of the same sleep complications that other healthy individuals are experiencing, but they're experiencing them at much higher rates. So let's start taking a look at that prevalence. Next slide, please. So going kind of condition by condition or sleep disorder by sleep disorder, first let's spend a little bit of time with obstructive sleep apnea. Now, obstructive sleep apnea is when breathing is repeatedly reduced or paused, or as some people say, stopped while asleep. Now, to be considered kind of an actual kind of event or issue, that reduction has to, or pause or stop, has to be at least 10 seconds for each event and lead to a significant reduction in oxygen flow and saturation of at least, depending upon your source, 3 to 4% from baseline. And each one of those, when it's pause sleep, we call it an apnea. When we see reduced airflow leading to that's the event, then we call it a hypopnea. And putting those together, we count how many apneas and hypopneas you have within a specific hour to give us a sense of whether or not we would say you have sleep apnea. For adults, we would say someone who has more than 5 events per hour is considered to have sleep apnea, versus for children, having even 1 event per hour during the sleep period is considered to have sleep apnea. Now, we have different types of sleep apnea, the most common being obstructive sleep apnea. And obstructive means that there's some type of obstruction somewhere that's causing this reduction or pause in sleeping. For children, that tends to be enlarged adenoids or tonsils, generally connected to increased rates of inflammation and infection. For adults, that tends to be sometimes a narrow pathway in the back of the throat, or the tongue actually not having enough air pressure, so it starts to slip back and lead to obstruction. And we'll come back to kind of those 2 different causes. Now, a recent systematic review, 2023 systematic review and meta-analysis found that across a number of studies, we found that around 43% of adults and 51% of children with sickle cell disease have diagnosable obstructive sleep apnea. Now, this is in comparison to other numbers I've seen in normal and the healthy population of individuals, which say somewhere between maybe 10 to 30% of adults who don't have sickle cell disease have obstructive sleep apnea, so incredibly increased risk. And we've also found that obstructive sleep apnea is related to increased sickle cell pain, increased risk of stroke, acute chest syndrome, neurological complications, and problems with academic and executive functioning. Next slide. Adding on to that, we have behavioral sleep problems, the most common being insomnia. And here, we're going to see 20 to 40% of children and adolescents reporting clinically significant behavioral sleep problems, and 40 to 70% of adults. So these are sleep problems that are not just being experienced, but that are interfering with people's daily lives, leading to reduced function. And in people with sickle cell, poor self-reported sleep quality has been related. It's primarily been examined in relation to pain, and we've seen worse pain outcomes, including increased daily pain, more ER visits due to pain, and worse pain interference. But we're also seeing how it plays into other factors for patients with sickle cell disease, including increased inflammation, high negative mood and low positive mood, possibly connecting into higher rates of depression and anxiety, and also fatigue. Our next major sleep problem to look at, next slide, would be periodic limb movement. And there's a lot less literature on periodic limb movement, but it does seem to be very common among patients with sickle cell disease. This is rhythmic, repetitive limb movements during sleep, generally movements of portions of the leg or foot lasting 2 to 4 seconds every 20 to 40 seconds. And what we've noticed is among reports of youth, we're seeing it in 20 to 42%, having periodic limb movements of greater than 5 per hour, which is considered to be clinically significant. Among adults, they're saying 70% who are reaching that threshold, and about a third of those having what we consider to be severe periodic limb movements. And from the limited research we have on periodic limb movements, they have been associated with cerebrovascular disease in youth with sickle cell disease and greater disease severity in adults. Next slide. So pulling this whole picture together, what we should be getting a very clear picture of is high risk of clinical sleep disorders within the population, and then being related to complications that are being managed for patients with sickle cell disease and are highly important, whether that be pain, frequency, severity, interference in healthcare use, to higher risk of stroke and acute chest syndrome and infection and inflammation, to behavioral factors like fatigue and academic executive functioning or anxiety, depression, and other mood issues. All of this should be putting, hopefully, the spectrum of sleep is highly important for us to get a good handle on. Now, I do want to dive a little bit into the relationship between sleep and pain, as pain is often what's considered one of the primary symptoms associated with sickle cell disease. It's most disruptive to people's lives, but also that's where I've spent the majority of my time looking at the sleep and pain relationship. Next slide. Now, I will say early on, when I first came into the field, the issue was, okay, yes, patients with sickle cell disease have sleep problems, but it's really that pain during the nights and taking opioids disrupt these normal sleep patterns. And so if we can get pain under control, sleep will naturally fall into place. And I will say that is sometimes the case for certain patients, but not for all. And this model kind of started developing out of the larger, I'd say, chronic pain literature that started to acknowledge poor sleep is essential for your body's physiological repair. Sleep is important for regulating inflammation and also for setting a person's pain threshold. And anyone who's ever had a poor night of sleep and then woken up in pain or sore and then gone back and had a nap and then felt better, that's the resetting of your pain threshold right there. But all of this started to come together to say to us that basically poor sleep might also be something that's helping to initiate pain and something that's exacerbating pain, and not just a consequence of the pain that our patients are experiencing. Next slide. And that's led us to kind of the more current research, the research that's been longitudinal both in adults and pediatrics, that have now started to really support the idea that it's not pain driving this relationship, it's sleep. And that when we look over time, if someone starts off with poor sleep and no pain, they're more likely to develop pain or have worse pain over time. And what we've seen is this kind of back and forth relationship, bidirectional relationship between sleep and pain. We've definitely been able to confirm it within patients with sickle cell disease, both youth and adults. And a lot of that literature is kind of going in line with the larger chronic pain literature, indicating that sleep is an important factor for us to think about if we want to manipulate people's pain experiences, both through biological mechanisms as well as through pain threshold and other mechanisms. Next slide. And that's led to kind of more current models of thinking as we start thinking about manipulating sleep to impact pain, and of course vice versa, is really getting a better sense of mapping these relationships between sleep and pain. Some of the proposed relationships, which we have preliminary evidence for, not specifically within sickle cell, but in the larger literature, have seen how sleep impacts everything from pain inhibition and habituation to inflammation and affective states to kind of underlying endogenous substances to how our brain is actually functioning. And I always like to add to this model, particularly as we think about the high rates of obstructive sleep apnea within or for patients with sickle cell disease, an additional factor for us to think about that might be an important mechanism. Next slide, or advance. And that's tissue hypoxia, in that we're already having a state of a body where that has reduced amounts of oxygen, and then adding on longer periods of time, whether you're sleeping for 6 hours or 8 hours or 10 hours, where your oxygen levels are continuing to decrease, and then deprive more and more of your tissue with oxygen, leading to higher rates of oxygen death. And I think that's important for us also to examine as possible mechanisms. And I think understanding these mechanisms are not just going to allow us to impact sleep, but all of the downstream mechanisms that might be leading to worse pain. And I'd also say with many of these, worse sickle cell disease outcomes overall. Next slide. Now, sadly enough, we have not really been examining mechanisms as they have played out for the relationship between sleep and pain when it comes to sickle cell pain. Our team is one of the first groups that have actually looked at possible mechanisms, and we first started focusing on affect, particularly positive and negative daily affect, finding once again a strong bidirectional relationship between sleep and pain severity. But also finding that the thing that seems to be partially driving or connecting these two factors, how much sleep or how well you slept the night before and the pain you're experiencing the next day, is not that you're having a significant increase in negative emotions like fear or anxiety or anger, but actually that our patients, or at least our pediatric patients with this study, we're experiencing lower positive emotions. And so those are going to be things like excitement and happiness and joy. And that it was a reduction in those that were helping the poor sleep have an impact on pain, and then vice versa, pain having an impact on sleep quality that night. And it also told us that that becomes another point when we think about intervention, is not just impacting sleep or pain, but also these emotional factors as a way of reducing inflammation and other symptoms. Next slide. Okay, so now let's talk a little bit about clinical implications of everything that we know. Now, for one thing, because we know that sleep is multidimensional, and we know that patients with sickle cell disease are prone to everything from obstructive sleep apnea to behavioral sleep problems, there's a host of ways in which we can assess sleep issues. Our primary one, most objective one, is polysomnography, so overnight sleep studies. And it is the gold standard for assessing obstructive sleep apnea and periodic limb movement. But then for assessing insomnia, we also have daily diaries, which have been a mainstay of sleep research and clinical practice for years, validated sleep questionnaires, and also validated clinical interviews. Next slide. So when we think about polysomnography, the overnight sleep study, this is what we envision. We're going to take you or your child, and we're going to take you to a strange place where we're going to connect up electrodes to look at everything from brain activity to airflow and breathing to muscle movement, all of the key aspects of being able to assess obstructive sleep apnea and maybe also periodic limb movement. And in child studies, because the first night is so awkward, just getting used to a new environment, we often recommend 2 nights if you're coming into a center or clinic. Next slide. However, in moving this along, we are making substantial strides when it comes to evaluation, and particularly at-home polysomnography. This has becoming the new standard for at least adult PSG. So people being actually able to be assessed within their home environments, sometimes with companies that will come in and set up people with the multiple leads that are needed, but also looking to technology to see how little we can get down to assess the same factors. And some of these things are also coming about commercially. We have devices like the Oura Ring, which is sold commercially, which continuously assesses overnight somebody's oxygen levels, therefore evaluating for dips as well as combined with movement. Or we have the WatchPat devices that are FDA approved, which provides for a sensor on a finger to look at pulse oximetry, so looking oxygen levels, the wrist-mounted device that looks at movement, and then an additional lead to examine respiration and snoring. And all of that sent via apps. And I believe that's validated as low as either 12 or 13 years of age. So I'd say most at-home polysomnography is not happening for children because none of that is validated yet. But for adults, this is really changing the game and moving us forward when it comes to sleep assessment. Next slide. Others are validated measures. Now, the Insomnia Severity Index is validated in adults, but a quick survey that'll get at all the mainstay items of insomnia, difficulty falling asleep, staying asleep, as well as how much these sleep issues are interfering and worrying individuals. This has clear clinical cutoffs and can be used within both research, and some people are examining it within clinical settings. Other ways that we're assessing sleep, next slide, are still going back to our daily diaries. Now, a lot of this is turned electronic, and there are many different ways that people can download their own diaries. Some of these are some of the older ones from the American Academy of Sleep Medicine, both giving us a sense of how much sleep disruption people are experiencing, but also what might be some factors that are helping to support poor sleep within our populations. Next slide. So going past assessment to thinking about treatment, when you're dealing with obstructive sleep apnea, treatment is required by a sleep medicine specialist. And the 2 standard treatments differ based upon whether you're dealing with children or adults. So for children, when I mentioned before, the obstructive sleep apnea is primarily due to swollen adenoids and tonsils, we have adenotonsillectomy, removal of the tonsils and adenoids as an effective treatment. I will say that we found adenotonsillectomy to be both safe and effective for pediatric sickle cell disease patients. We'll go over some of that data a little bit later. For adolescents and adults, we move a little bit down the road to CPAP, continuous pressure airway, or BiPAP. Now, this is different because remember, here we're not dealing with obstruction due primarily to adenoids and tonsil enlargement, but instead to kind of movement of the tongue and other obstructions. And so with CPAP, what you're doing is trying to force enough air to keep the airways flowing, to keep oxygen continuously coming and entering the body. Now, I'd say we are still working on making these devices more patient-friendly. So we still do have like the mask, and we also have like the at-home devices that are pushing air. But we do have some interesting developments that we hope are going to be coming down the line. One of which has got the most excitement is the micro CPAP that would fit over like just a person's nose. Right now, from what I've heard, it is not commercially available. They're still under development, and they're not quite providing enough pressure for people with more severe or moderate obstructive sleep apnea, but maybe they might be available in the future for people, at least at this, with these iterations, for people who have more mild obstructive sleep apnea. Next slide. Now, when it comes to addressing behavioral sleep problems, generally, we're going to want to see what other factors might be playing into it. Everything from, yes, pain and pain medications, and then focusing in on sleep hygiene behaviors. Do people have set bedtimes, regular sleep schedules? Is their environment set up for sleep? Are they exposing themselves to bright light when they first wake up? And for those who are not able to benefit fully from sleep hygiene as a way of improving overall sleep quality, we move to the gold standard. Next slide. Which is going to be the gold standard treatment, first line treatment, is cognitive behavioral therapy for insomnia. And this is considered, because of its effectiveness, the first line treatment for insomnia by the American College of Physicians and the American Academy of Sleep Medicine. So far, CBTI has well outperformed any type of drugs or medications. Reports indicate improvement in 70 to 80% of individuals with insomnia. Currently, there is an ongoing clinical trial assessing the influence of CBTI in adults with sickle cell disease. So we are still waiting for that information, but in the general population, this is generally what you're going to find. And it is provided by a psychologist with expertise in behavioral sleep medicine. Next slide. Now here to provide an overview of exactly how, or the model for how CBTI works. It's based upon this model of, well, we call the triple P model, where you start off with a risk factor for us having sickle cell disease, or even being in a specific developmental state like adolescents. Adolescents are notorious for, unfortunately, being the worst sleepers. This leading to some type of precipitating event. It could be pain in the night. It could be hospitalization. As we know, being in the hospital, people wake you up multiple times. And there's often light sources that are keeping you awake. It could be underlying overactive bladder issues or medication effects. But let's say, yes, you have returned home from the hospital or you're no longer in pain. However, it's left you with what we call perpetuating things. While you were awake in the middle of the night, maybe you started playing with your phone or watching TV or other things that are reinforcing you being awake, or doing other things when you should be sleeping. And eventually, those triggers and maintaining factors are going to come together to create a conditioned response. So even when your pain is not there, and even when other factors are not there, it becomes harder and harder to sleep. CBTI is all about addressing those perpetrating or maintaining factors as a way of hopefully eventually eliminating that conditioned response, so that your body does not automatically wake up at 3 a.m. or 4 a.m. or 5 a.m. And instead allows you for good nights of sleep. Next slide. I think the cornerstone of CBTI that I also like is that it's supposed to equip people with strategies. So yes, you may still have a pain event happen in the future. You may travel, which might disrupt sleep. So you might address or find triggers that happen in the future. But now that you have this tool set of strategies, it'll also help you recover from disrupted sleep more quickly. And those things include everything from relaxation training to targeted use of sleep hygiene and stimulus control. Next slide. So far, everything that we've gone over has said patients with sickle cell disease experience a lot of sleep problems. They're varied. We've got some strategies that we know work in other populations. So what do we have to kind of think about or move forward with? And I'm going to say here, this is where I'm going to go a little bit piecemeal to talk about problems that we know in relation to thinking about how do we get screening taken care of for patients with sickle cell disease when it comes to sleep, mechanisms of influence, identifying the impact of treatment, and then also thinking about access and dissemination of both treatment and assessments. Move forward. Sorry, next slide. Okay, so we're thinking about screening within the clinical setting, and I particularly am enjoying speaking to this group because you guys have been looking at thinking about screening and access to care. We know that we have to think about things that can be easily questioned or asked within a fast-paced clinical setting. And to do that, we have to know what are going to be the risk factors that are going to help us identify people who are at risk for sleep problems. Now, when it comes to OSA, probably one of the best assessments we have is just a physical assessment of snoring. A study of 106 children with sickle cell found that physical assessment of snoring has a sensitivity of 70%. So that's telling us that it's just asking someone if they snore in the night is a pretty good indicator of whether or not they're going to be able to identify people who are, or at least who possibly have obstructive sleep apnea. However, the specificity of this, which is going to give us a sense of whether or not, or where we might identify a lot of people who don't have OSA, is also not where we would like it to be. So that's not going to be a perfect screener. We've also found that priapism history is associated with oxygen hemoglobin desaturation. So that's going to be a primary mechanism with OSA, as well as periodic limb movement. Priapism history is at risk of periodic limb movement. What we need, however, is a clear screening tools that are going to put together our best risk factors for understanding what is driving, or at least what can give us a sense in clinical sense of referring people for OSA. Now, when it comes to behavioral sleep problems, we're finding the same risk factors as we do in the general population for behavioral sleep problems: higher BMI or being overweight or obese, older age, being a woman, or when you're unemployed or looking for a job. And once again, we don't have clear screeners that have been tested within clinical settings for behavioral sleep problems. So I'd say this is an area for future work as well, is thinking about and being very clear about what are the risk factors and what's going to lead to referral. Next slide. So I wanted to pull out, this is some data that we looked at in relation to thinking about behavioral symptoms and risk factors. Our team did a study of 88 youth with sickle cell disease who completed ecological momentary assessments, so they're twice daily surveys for up to a month. And we found that 97% reported some type of sleep fragmentation, so waking at least once during the night during the EMA period. And from the figure you'll see on the right, what you'll notice is we even had one person who was waking every night during the EMA period. Now, we naturally assumed, oh, this is due to pain. But instead, we only found about 20% of the time were people reporting that it was due to pain. And most of the time they were waking, or the sleep fragmentation was being supported by needing to go to the bathroom. Actually, going to the bathroom 45% of the time just by itself, with an overlap of both pain and having to go to the bathroom 11% of the time. And what that was telling us is that we also have to think about how all these other factors are likely either impacting sleep. So things like that we already know about: high rates of overactive bladder within the pediatric sickle cell population, and how that might need to lead to sleep referrals. But another possibility is that nocturia, or having to go to the bathroom at night, is also an indicator in healthy populations of obstructive sleep apnea. And how much overlap are we dealing with when we think about this insomnia symptom with possible obstructive sleep apnea? Next slide. And so that leads me to think about, just because we've identified or are concerned about one problem, whether it's obstructive sleep apnea or insomnia, sadly enough, doesn't mean our patients aren't experiencing both. Now, this is based upon general population data, so not specific to sickle cell disease. But what they have found is that 30 to 50% of patients with OSA report insomnia symptoms, and that 30 to 40% of patients with insomnia fulfill criteria for OSA. And this is going to be particularly important when we think about sickle cell disease patients who are, once again, at high risk for both. Next slide. Now, there is only one study that's actually evaluated both of these two different types of sleep problems at the same time. It was a cohort study of 32 adults with sickle cell disease, referred to a sleep center for evaluation of sleep problems. And they found that 25% of the overall sample had this comorbid obstructive sleep apnea and insomnia, also known as COMISA. 19% had sleep apnea only, and 41% had insomnia only. Now, what's particularly important for us to understand and know about this and possibly get better data on COMISA is that in other chronic pain populations, COMISA is associated with more severe pain and healthcare use in response to pain, including opioid use. COMISA has also been found to be harder to treat than obstructive sleep apnea or insomnia alone. And so I think this is an important area for us to be thinking about, is understanding COMISA. I think the other thing that we need to move forward with is identifying the specific mechanisms that play into the sleep pain and sleep, and I'd say sleep and sickle cell symptom relationships, if we want to be able to both understand how possible sleep treatments might impact sickle cell patients, but also think about, for those who are experiencing poor sleep where we're not able to address their poor sleep issues, how do our other treatments that might address some of these issues reduce the impact of poor sleep on outcomes for our patients. Next slide. I also want to pull in this question that hopefully has been drifting through your head, which is, does treating sleep problems actually reduce sickle cell symptoms? And I will say, based upon this preliminary evidence, it seems promising, though I will say we have very little evidence at this point. First, let's look at non-invasive ventilation, which also includes CPAP under that label. There was a nice RCT, 6-week RCT of prophylactic overnight auto CPAP with oxygen supplementation for youth with sickle cell disease, which found it to be both feasible and safe, but also leading to reductions in pain frequency. This was not a population that was already identified to have obstructive sleep apnea. There's also an interesting retrospective review of hospital discharge paperwork for youth with sickle cell disease. The original findings indicated that those who had an OSA diagnosis, so obstructive sleep apnea diagnosis, were more likely to have neurological complications. However, when it was noted that the youth received non-invasive ventilation or mechanical ventilation, that relationship disappeared, indicating that treating through this method might actually reduce some of those downstream complications. Then for adenotonsillectomy, it's also been found to be safe for children with sickle cell disease and associated with decreases in apnea-hypopnea index, increased oxygen levels, cerebral blood flow decreases, and reduced ER visits. Now, as you will notice, none of this research was done with adults. I do want to point that out. And does treating insomnia, because that was primarily focused on obstructive sleep apnea treatments, does treating insomnia reduce chronic pain or other sickle cell symptoms? We have, unfortunately, even less data. We're still waiting for the results of the clinical trial. But based upon non-sickle cell literature, things also sound very promising. A systematic review and meta-analysis of RCTs, so randomized controlled trials, indicated that CBTI for patients with chronic pain both led to significant reductions or improvements in sleep, 81% at post-treatment, 71% at 6-month follow-up, and reductions in pain. 58% reported less pain at post-treatment and 57% reported less pain at 6-month follow-up. And you have to remember, CBTI does not directly focus on treating pain, but instead is exclusively focused on treating sleep. Another systematic review and meta-analysis that compared CBTI, so cognitive behavioral therapy for insomnia, to cognitive behavioral therapy for pain, and a hybrid cognitive behavioral therapy for both insomnia and pain for adults with both chronic pain and insomnia, also found very positive results, finding that CBT for insomnia and the combined version were significantly more effective than controls for improving pain, but also seem to be more effective for controlling pain, reducing disability, and reducing depression at post-treatment. Next slide. Next slide. So all of this is coming together to say that sleep and addressing these sleep problems might be important, but I think the other piece we have to think about is access and dissemination. I've already talked about kind of the movements in the field in relation to assessment, getting it from the clinic to the home, but I also wanted to mention the movement that's also happening, not just for obstructive sleep apnea, but also for insomnia. And for insomnia, I'd say we're having the rise of digital therapeutics. So these are online or app-based programs that are going to teach patients all of the techniques of those cognitive behavioral therapy interventions. The two that have the most empirical evidence are Sommerist, formerly web-based shut-eye program that's now being offered via app, and Sleepio that I believe was developed in the UK and has also found a lot of clinical significance. And I'd say that's on the adult side. On the pediatric side, there's this wonderful commentary by Ariel Williamson that really kind of provides a detail of digital pediatric sleep interventions that are coming online or being tested. And we're definitely waiting for some ongoing RCTs related to CBTI, not for patients with sickle cell disease, but for adolescents with comorbid headache and insomnia. Next slide. But I'd also want to put out there that the world is opening up. As sleep becomes more and more of an interest to the commercial world, we have to also think about these other pieces that are playing into it. The rise of melatonin use, which is available over the counter, neurostimulators, white noise and aromatherapy, biofeedback devices. All of this are being used, weighted blankets I'm hearing a lot about from patients. Next slide. And all of it is being marketed to our patients, marketed to people living with sickle cell disease, marketed to us, to everyone. And I think it's going to be very important to start to look at the mechanisms that they're proposing to influence as they influence sleep, and also see how patients are accepting it. Are they leading to better outcomes, and how that downstream might also lead to better overall sickle cell disease outcomes. Next slide. So overall, I feel like I've probably gone over a lot of information, but I hope what you take away is that sleep problems are very common for people with sickle cell disease, and that it's important to assess these sleep problems as part of standard clinical care, as well as their outcome or their impact and comorbid conditions. And that there is a lot of promise that we're seeing in possibly that addressing sleep problems in people with sickle cell disease may be effective for managing other sickle cell related complications, but we still have a long way to go in relation to testing that hypothesis. Next slide. And so that kind of finishes my overview, and I'm very open to questions.
Wonderful. Thank you so much, Cecelia, for that presentation. Found it both interesting and really informative. And so with that, I'll turn it over to Jackie to help us facilitate the question and answer portion. And again, just as a reminder, folks can type in questions in the chat box feature of this webinar, as well as the question panel. Jackie?
Thank you, Nyani. Thank you, Dr. Valrie. That was, I mean, I think the numbers on the prevalence of sleep disturbances, although maybe shouldn't be surprising, were surprisingly high to me. I did not know that. So thank you for that. I'm just, as questions kind of come in, I do have a couple for you. Just mainly, are there, just thinking about all the different strategies that are out there, is there something that clinicians or people should really keep in mind in terms of individuals with sickle cell disease? Is there any differences in how those should be treated for sleep disorders?
I think what I'm noticing so far is it's not as much about kind of differences. I think it's going to be incorporating screening practices into sickle cell care. And I've noticed, you know, in relation to thinking about referral and getting people over to be evaluated so that they can have treatments, I think in relation to the effectiveness of treatment, I've, anecdotally having talked to a number of sickle cell patients, some of whom have, been on CPAP or had adenotonsillectomy, I've heard very positive results. They've talked about improvements in sleep. And so I think that the standard treatments, but it's really going to be less about maybe modifying things and more about getting it to our patients, dissemination and implementation.
And from your experiences having this this screening included, something that's easy to do, like does it have to be covered by Medicaid? Is it something that is kind of a low cost aspect to being able to easily include it into clinical practice?
Well, when I'm thinking about screening, I'm not thinking about, oh, well, let's go ahead and put a device on someone. I'm instead thinking about when people are coming in for maybe their yearly or 6-month check-in with their provider, us even asking questions of how are you sleeping? I will tell you, we are currently gathering data on adult patients with sickle cell disease. And often as I introduce the study and say, we are hoping to take a look at sleep in patients with sickle cell, I started to see this look run over people's face. And I say, sometimes people with sickle cell disease have problems falling asleep, staying asleep, or feeling refreshed in the morning. You can see people's faces say, yes, that's me. And I think even asking the question is the first part of screening so that we can think about referral. And that's just going to take time versus money or reimbursement by Medicare. I think the next stage, which is getting them over to a pulmonologist or a neurologist for the PSG, I believe with referral from sickle cell, I don't know of any of our patients, even who are on Medicaid, who've had a problem in relation to paying for or being really having reimbursement for being able to be evaluated for sleep disorders.
Right. Thank you. And don't see any questions come in, so I'm going to just go through one more that I have, if you don't mind. And just what strikes me a lot is just the potential impact on kids in school. And from what we hear, I mean, a lot of kids maybe sometimes have trouble going to school every day, and a lot of it is because they're tired or they're just kind of have a lot of fatigue. And I'm just wondering if you've heard from your experience, like how to involve schools in this, or school nurses, or how, the education or awareness factor on their end to let them know what could potentially be happening with students in their district.
Well, I know, having worked with some of our pediatric patients, oftentimes when we're seeing struggles in school, that's going to fall into, depending upon how things are classified in your state, either a 504 plan or an IEP, where particularly when we're dealing with fatigue within schools, sometimes having it be built in for rest periods. When we're dealing with fatigue, I've seen that happen before. But I think that's kind of how I've seen people work with schools, as well as providing education to schools about some of the complications associated with sickle cell disease. That sometimes it is associated, kind of being very clear it is an anemic disease, being very clear that it's going to be highly disruptive in relation to sleep, and that some of the behaviors that both teachers and other school personnel are seeing are not always defiance, but are instead exhaustion.
Right. So I want to invite anyone else to, if you guys have any follow-up questions, now is the time. You can also send those questions to us directly, and we could pass them on to Dr. Valrie as well. Give them another minute. And as we're thinking, since we collect data, for instance, that has already been collected, administrative data, Medi-Cal claims data, is there anything that you can see in terms of what our type of SCDC programs can do with our data that would help kind of further kind of the knowledge around this, since we're not able to do obviously clinical trials or anything of that nature, but I'm just wondering how we can best leverage our data as well.
Well, I think one thing that's particularly important are thinking about kind of rates of sleep disorders that are already that should be like diagnosed and in people's records. And seeing how, when patients do have identified diagnoses, whether insomnia or obstructive sleep apnea, how those patients are doing and what type of treatments that they are receiving, or if they're receiving any at all. Like, I think that that's been a pipeline that I've been very concerned about, is sometimes even when we have referral, it doesn't always mean that someone eventually receives treatment, because there is a process of going to be further evaluated by a pulmonologist or a neurologist, and then going through treatment. And then are they currently on treatment? And I think if I know your type of data well, that type of claims data, much of that should probably be very much embedded within it, and could probably provide some very interesting insights.
Okay, I think they were just thanking you for that. It would be a good addition to the primary care history. And then Kristen Meridian wrote, increasing positive emotions and interesting potential therapy, incorporating more fun into the visits. How else can this be done?
Well, I think that definitely we talk about incorporating more fun, but we also talk about, I guess within my field of psychology, we talk a lot about positive psychology, and some of it is kind of hope and optimism. And I think sometimes you can see when some of our patients get kind of worn down by a lot of negative messaging, or new pain, new diagnoses, or more challenges. And so I think kind of, yeah, well, we talk about mood enhancing behaviors and focus. And some of that is, I will say within my field, we have it called acceptance commitment therapy, where it really is about focusing on kind of, does this person have goals? You know, how are step-by-step movement, or a movement more towards kind of things that are exciting, or things that are goals in their lives? How can we keep people kind of tracked to their goals and to positive outcomes, versus, unfortunately for us, ruminating on, or just having this cycle of thoughts all about pain and hospitalization and everything negative that's happening in their lives. And so sometimes it's about breaking those cycles, or at least continuously breaking those cycles, because they can be very easy to fall into when you're continuously struggling. And as we said with our warriors, fighting against this disease.
Absolutely, thank you. I think that's an excellent point. See, I don't see any other questions. Thank you, Dr. Valrie. This was really informative, and it gives us some ideas for kind of what to look for in our data as well to kind of help support this. And I will pass it on back to Niani.
Okay, thank you so much. Yes, and a special thank you so much, Dr. Valrie, for your presentation today. Folks will see on the screen now all of the various ways that you can get in touch with us and our program to receive more information about things like our webinar, as well as our newsletter, as well as provide feedback to us. And if you have questions that you weren't able to ask today, but you think of them later, please feel free to send them our way using all of the various methods and tools on the screen. Upon ending this webinar, there will be a brief 3-question survey where you can provide feedback on the webinar, submit questions, feedback, and suggest future speakers. So please take a moment to fill that out, as we would greatly appreciate it. And I just want to take the time to thank everyone who participated today for your attendance. We will go ahead and conclude this session. I hope everyone has a wonderful rest of their day. Thanks all. Bye-bye.